to the diagnosis and treatment part, but because the investigation part is already discussed, I will just go through that one and mainly concentrate on antibiotics and supportive therapy, and few cases where I face challenged in my clinic. We'll discuss about that one. It is more, I think it is more interesting than theory. So objectives of the management: evidence-based diagnosis and treatment, clinical assessment of severity to decide whether to treat the patient in the hospital or in home-based treatment, appropriate antibiotic medication depending upon the case type, whether it is for community-acquired pneumonia, hospital-acquired pneumonia, ventilatory associated pneumonia or atypical, supportive care, that is most important in pediatric any disease, but the two pneumonia, identification of treatment failures and complication as early as possible and managing immediately, and some pneumonias in special situations, and prevention. The principles of the treatment is all children diagnosed with bacterial pneumonia should receive appropriate antibiotics. Antibiotics should be started as soon as the diagnosis is established. Oral antibiotics is preferred because most of the pneumonias can be treated with oral antibiotics if the patient is accepting and oral feeds and stable. Indications for hospitalization are only few. If the age is less than 3 months, at whatever may be the severity, we have to admit. And severe complicated pneumonia, we have to admit and treat. And if the patient is having hypoxia, cyanosis, apnea, or neurological toxic irritable drowsy conversion, that may be because of disease or hypoxia, immunocompromised states, kids, and vomiting, babies having dehydration, not tolerating oral medications or food. And if it is everything goes well, if the appropriate treatment is given, even after 48 hours, the patient is not responding to the therapy, then you have to consider for hospitalization and treatment. Investigations, because pneumonia is a clinical diagnosis is most important. The clinical assessment and diagnosing, diagnostic imaging, blood tests, mycological tests. So just I will highlight only on clinical assessment. So because this is more clinical assessment resources limited settings, especially by this is recommended by WHO. Even ASHA worker or Anganwadi worker can diagnose the pneumonia and whether to treat in the OPD basis or when to refer the patient to the hospital. 3 criteria is given. One is tachypnea tracking, that is rapid respiratory breathing count. Depend upon the age, whether it is less than 3 months, any more than 60 breaths per minute, and as is up to above 5 years, up to 30 more you have to consider. Second one is oxygen saturation. The pulse oximetry is important role, even it is for all ASHA workers and everything it is given now, or especially post-COVID time. So any hypoxia less than 92% recorded in, it has to be referred to the hospital. And physical signs, that too majority signs can be picked up by the ordinary health workers like ASHA workers, like lower chest retractions, nasal flaring, grunting. And if they can, if any sub-paramedical auscultation person is available, if the auscultation is suggestive of any crackle or bronchial sound, that has to be patient, this is for the diagnosis of pneumonia. And if the patient is stable, they can start the oral, that is therapy with supportive care. And the imaging, diagnosing with the X-ray and USG. So routine X-ray is not recommended in community-acquired pneumonias. Only indication only in severe cases, non-responsive, or if the patient is hospitalized, it has to be done. So it helps in distinguishing is a lobar or interstitial, whether it is a interstitial, more of a viral, and lobar, and detection of a complication if they are not responding after 48 hours, that is required. And repeat X-ray is not required if the clinical response is good in all cases, hospitalized or OPD basis, because radiological clearance takes a long time. Unless the patient is not responsive or is worsening, then only have to repeat the X-ray and see. And USG now very highly sensitive and specific. Even admission patients, the transport point of care transducers can help in distinguishing the early detection of complications, especially empyema, effusion or empyema. It can be picked up. Focus. So blood tests. So I think it's already discussed in the last week. So we'll go switch. Microbiological tests also. Blood culture is yield is very low. Especially the pleural assessment, pleural fluid, if it is trapped, that is more helpful. Culture of nasopharyngeal secretions won't help much because most of the common cell will be there, unless it is in special situation the bronchial lavage done. That will give in resistant cases or complicated, it will help. So now just antibiotic choices in non-severe pneumonia, that is community-based pneumonias, depend upon the age. So less than 3 months, all babies has to be admitted. There is no question of treating in OPD basis if you diagnose the pneumonia. 3 to 5 years, first line is amoxicillin. Second line, amoxiclave or cefuroxime can be used. More than 5 years, amoxicillin is the first line, that time age also. In second line, drugs, azithromycin, levofloxacin, moxifloxacin can be used. In penicillin hypersensitivity cases, cefodoxime can be used as a first line, and the second line, levofloxacin and azithromycin can be used.
Less than 3 months?
Hospitalization. Here it goes. So antibiotic in community acquired pneumonia when a patient is hospitalized, less than 3 months and more than 3 months, only 2 criteria divided. Common bacteria depend upon the age group, where in first 3 months we'll expect GBS or enterococci and listeria. The ceftriaxone and cefotaxime are the drug of choices, the first line. And second, if you are suspecting mass MRSA, then vancomycin or clindamycin can be used. In atypical, in any age, it is azithromycin, macrolides. More than 3 years, 3 months, ampicillin, first line, common bacteria, ampicillin, amoxiclave or ceftriaxone is the drug of choice. And if they suspect MRSA, vancomycin or clindamycin, linezolid can be used. Antibiotic in special situations. In hospital acquired pneumonia, should suspect bacteria like Staphylococcal aureus, Enterobacteria, Pseudomonas aeruginosa, anaerobic bacteria. So empirical antibiotics include amikacin, means any aminoglycoside can be used, but amikacin is most of the times it is used, plus one of the following. So these antibiotics, piperacillin, tazobactam, meropenem, ceftazidime or clindamycin can be used. If it is MRSA is suspected, vancomycin, because as a just general practitioner, these medicines, second line medicines are not used for almost 15 years. Antibiotic in aspiration pneumonia. If it is aspiration is community acquired pneumonias, then amoxiclave or ampicillin sulbactam can be used. And if it is hospital acquired, you have to go hit the bug for rapidly. Piperacillin, tazobactam, and if you are suspecting the MRSA, vancomycin can be used. Antibiotics in the ventilator acquired pneumonias, associated pneumonias, depends on culture sensitivity reports of the institutions is the must. If the institution doesn't have a policy, antibiotic policy for that one, recommended use of piperacillin, tazobactam with amikacin plus vancomycin. All the 3 drugs is recommended. In PCP, where pneumocystis is urinary, trimethoprim sulfamethoxazole is the drug of choice all age group, but doses are important. That is double dose, almost like usually 7 to 10 will be the routinely used trimethoprim. This combination of 15 to 20. And duration also, community acquired pneumonia is now they are telling 5 days is sufficient or maximum 7 days. Here we have to give almost double, so 15 to 20 days is recommended. In atypical pneumonia, any macrolide, preferably azithromycin, is used that for 5 days. Antibiotics and antivirals in viral pneumonias. Routine antibiotics is not recommended. Use of antivirals in viral pneumonia is questionable effectiveness with a few exceptions. In sporadic cases or epidemic and pandemics in viral pneumonias, antivirals like Astromycin, ribavirin are used, but they are helping reduce the severity and duration if started early. If you start after 48 hours, still the significance is questionable. Antibiotics routinely is not used, but when the patient is admitted, especially with severe pneumonias or requiring ventilation, empirical antibiotics are used. So the most important care is in pneumonia is supportive care, which definitely reduces the morbidity and mortality. So in that one, criteria aims are just to increase the oxygenation and reduce the work of breathing. Third one, support faster recovery, reduce the stress of psychological support by psychological support to the children and family, reduce long-term complications, and reduce the morbidity, mortality as if it is everything goes well, it is good. Supportive care. So at home, the fever, the drug for management of fever is paracetamol is the drug of choice. 15 mg per kg per dose to keep chilled comfortable. It is mentioned avoid tepid sponging. So there is a question everyone is discussing every day. So for me, I am advising lukewarm sponging. At least when the fever is there, they should do, parents they should do active and do some work. So let them sponge with the lukewarm water, not definitely with cold water or ice cold water, and maintaining a hydration. And one more thing I want to add is, even though theoretically everywhere paracetamol is a drug of choice, we are using that one. When the patient after 1 to 1.5 hours also the fever is very high, more than 100 or 101, it is persisting, we have to give some remedy for it one. So I use ibuprofen as a second line. Once after 1.5 to 2 hours, if the fever is persisting where they can't use next dose of paracetamol immediately, with maintaining the hydration, and I will tell them at least give some food or milk, don't give in the empty stomach, that is. And cough, so as usual we know cough suppressants are avoid cough suppressants, and in giving frequent liquids, it will help in the cough also and maintaining the hydration also. And household remedies, so even if we say no, they will use it. And definitely I think when we coughing, we also uses these medicines. So when the cough is not working for any the commercially available medicines. No role of nebulization, but when wheeze is suspected, especially associated with viral, nebulization or inhalers is can be used. And vomiting, that is most of the times is post-tussive vomiting. So means antiemetics may not work, but if it is persisting, so sometimes we will use and to maintain, we'll try to, first we have to control the cough, hydration, that time, so we can use antiemetics. And maintain the proper hydration is more important. One is for rapid recovery. Second one, if it is a dehydration, the secretions becomes thick, more thick, especially with rapid breathing is going on. So definitely hydration is required. And identification signs and deterioration of serious illness has to be explained. And access to the referral facility should be provided. So that is most important, safety net. Provide caregivers with a written information, not just telling the orally what to do, when to come back or when to reach. Written information has to be given on warning signs, how further health care can be assessed, where they can reach and where out. And if it is for just follow-up, appointment has to be given time and space, whether to come to the hospital or clinic, that has to be. Provide information about direct access. Most of the times we are not available, or especially in clinic, who are practicing only in clinic, where the health care provider is available round the clock. So they should not think, wait till in the morning, we'll let doctor open the clinic and we'll go. And supportive care at hospitals, that is fluids, oxygen and nutrition, main three things. Fluid therapy. So because of rapid breathing, fatigue, they may not able to take adequately, but that has to maintain. In non-severe cases, including breastfeeding, oral feedings has to be continued and encouraged small frequent feeds. Like once in 15 to 20 minutes, half an hour, give some sips of water or liquids, ORS, fresh juices, anything. And once in 2 to 3 hours, you can give some food, little bit. So when in the severe cases where oral intake is not possible or very less, or there are nasogastric tube or intravenous fluids can be used. So putting the nasogastric tube in and maintaining the hydration is quite difficult, especially small babies. Their mouth breathers, if the nose is already partially blocked because of secretions, if you block one more nostrils with a tube, it is difficult. I don't think it is ideal, but it is recommended. So IV fluid, whenever the patient is admitted, we giving the IV fluid, antibiotics, so we can give the IV fluids. Indication for IV fluids, any neonate or young children with severe distress. So the tube and persisting vomiting. Even if you give the nasogastric tube feeding, if the baby coughs and vomits, it is useless. Then IV fluids has to be given. Fluid intake should be calculated taking into the account of possible dehydration, what is available, and greater loss because of fever and rapid breathing, what is Holiday Sager's formula, that is per hour 4 ml per kg for up to 10 kgs per hour, or 2 ml per kg per hour from 10 to 20 kgs, 20 and above 1 ml per kg per hour, or previously what we remembered is 100 ml up to 10 kg for 24 hours. This is that is for hourly. That hourly is most helpful. Actually, that is anesthesia people, because they manage very for short period, they will calculate that one. For us, we have to keep the baby for 24 hours. So that is 100 ml for up to 10 kgs. Then 50 ml from 10 to 20 and 20 ml per kg. That is ideal. And monitor fluid balance and serum electrolytes is most important, especially sodium, because this SIADH is more like almost like 30 to 40% kids with a severe pneumonia can have it. So where that is a complication, even though patient is responding because of for the pneumonia and infection, they become bad because of this entity. Oxygen therapy, next one, is most important is to prevent hypoxia, because hypoxia associated with severe can occur with most of the severe complicated pneumonias. It increases the mortality, and the goal of oxygenation is not like keeping around 94, 95 or something, just 92 to 94 is sufficient. So, and indications in any severe complicated pneumonia with increased work of breathing, tachypnea, and SpO2 less than 92, you have to supplement, give the oxygen. Methods of oxygen delivery: heated and humidified oxygen is recommended for all. WHO guidelines says no face and head box oxygen. Only nasal prongs, nasal catheters, nasopharyngeal catheters can be used. But British guidelines says you can use any nasal catheter, head box or face mask. There is no strong evidence for any best method available. So it can be used anything. So next is acceptance and availability make the sense. Other modes of delivering oxygen is CPAP, HFNC, invasive ventilations. These are in severe cases. Nutrition, oral feeding should be maintained as much as possible. Diet for pneumonia should focus on hydration. Proteins and proteins for the tissue repair. Nutrient dense food to boost immune system. Would provide vitamins, minerals, that is most important. And role of bronchodilators in and chest physiotherapy. Bronchodilator, especially with the pneumonia associated with viral infections, where you can be MDI with spacers can be used, or nebulization. So still we are using that also. So even the pulmonologist says only MDI is preferred, avoid nebulization. And chest physiotherapy and breathing exercise definitely helps. It helps in the evacuating the exudates and secretion of the airway to keep relieving the airway obstructions. No clear concrete evidence that support the chest physiotherapy in pneumonia. And iliacs, breathing gas mixed with helium and oxygen, I don't know what is it. Helium less dense than the air generates less resistance in the airway. It may be used in the future. I don't know whether it's started using or still it is in the theory only. Just after this, we will go for a little bit of a few cases, 5 cases, and we'll with the background what we have observed now, we'll decide. 5 years presented with high grade fever for 3 days, mild cough with breathing difficulty. This examination findings: 60 breaths per minute, SaO2 86 in room air, decreased chest movements in the right lower part, and bronchial breathing and auscultation. Diagnosis and management. Whether hospitalization is required, either is non-severe pneumonia or severe pneumonia. Management wise, whether it's OPD treatment or hospitalization, that has to be decided.
Should we tell you?
Sir?
Yes, supposed to
Yeah.
take it now.
Right.
I thought
Now
about
we have severe pneumonia. What the admitting nowadays?
What the you have to admit. Hypoxia.
Even though hypoxic is running, we have to admit.
Whether to investigate or not?
X-ray. Admit double on the X-ray.
Once oxygen requirement is there, you have to investigate.
It's a severe community acquired pneumonia with hypoxia. Needs admission and start IV antibiotic and de-escalate as soon as possible and send them home.
Yes.
But the
Thank
question comes because all of them start with vancomycin, whether it is necessary or not.
No, no. No, no.
So-
This is a community only.
Community wise is also
In a
subtract.
resource poor country, even ampicillin is good enough. Or crystalline penicillin is also good enough. If it's available.
Actually, to be around 15 years back in Vinayaka, we are given this crystalline penicillin for pneumonias.
Nowadays they give ampicillin. Even in Indira Gandhi and so on, they don't use it now. They use community ampicillin.
But important
When
clinical
do they use vancomycin? They use vancomycin.
Staphylococcus is there.
Staphylococcus. Suspected staphylococcus.
Sir, they start vanco.
Then de-escalate.
Because they tell probably you.
Madam, we are talking about the ideal situation.
An important clinical symptom would be cough. It's not the predominant complaint when it is a pneumonia.
Yes, yes,
Right?
yes. But
Cough
it's
itself
not,
is not a predominant.
most of the time you won't find the cough at all.
You revise your diagnosis.
Yes.
Yes.
It may be mostly reactive.
Yes.
Cough is very less.
That's why you
Yes,
mentioned that.
yes, yes. So that kind of cases we are managing in our hospital.
If the same child were to come to the clinic without hypoxia, reasonably active, you would
Oral.
put them on oral amoxicillin and
And
observe.
observed for 40 years. Yes. Second case, 15 days refusal of feeds and rapid breathing. 15 days.
Babies.
Newborn. Sick looking, multiple pustules on the trunk. Diagnosis. What kind of pneumonia?
Staphylococcus.
Because multiple pustules on trunk.
Yeah.
Here vanco will come.
Right.
Yes. Support.
Lots of.
If it's available.
Yes.
It's MSSC.
Third one, it is 10 years low grade fever for 10 days, cough, fast breathing, relatively comfortable, and saturation is good. Bilateral crypts and some wheeze is there. So as usual, it is only one. So more, especially in the older age group with not sick looking, we should suspect atypical, especially prolonged mycoplasma. This is Yashoda, 3 years school going in flu season.
Macrolide resistance, you are incomplete now.
Which one, sir?
Macrolide resistance in mycoplasma. How common is it? Anyone can.
It is increasingly common. The percentage I don't know. So maybe that's what Dr.
So
Balaji-
would you consider giving macrolide first or something else you or toxic first?
In a suspected mycoplasma, it's always macrolide only first. Macrolide.
Actually, many hospitals have changed.
Doxycycline.
They're using
Doxycycline.
Because all parents are starting azithromycin
Uh-huh.
and then coming.
Levofloxacin third and above 8
And this is for discussion.
steroids.
3 years school going in flu season, fever for 3 days, respirated for 40, saturation is good, bilateral crypts and wheeze is there. Diagnosis and treatment when you know it is a flu, whether to investigate for flu or not, because I have seen with side labs who are having in their clinics, they are doing all. Most of the kids they are doing flu PCR this one, test, strip test.
No investigation as an outpatient, only if they're hospitalized with a severe, then you investigate.
Mild to moderate, mild is no treatment also, means even the antiviral is not required. Moderate, give the treatment, observe. Antiviral you can use it without doing the test. Only severe and admission is required, that time has to. And supportive care, antiviral, whether to give amoxicillin means antibiotic with that one or will give both. But if they after 3 days, sir,
Even after 3 days, it depends on the clinical picture.
Yes.
Just reassess and
And
Yeah,
it
out-
will reduce viral shedding and decrease transmission. So even later on, it's worthwhile starting for certain minutes.
Also
Even if it is more than
48 hours to prevent community.
Yes, to reduce transmission and spread within the community.
That's good point. Thanks. So after 3 days, if it is still the condition is worsening, then because we have secondary infection we have to suspect, maybe that time we have to consider for antibiotic. This is a very complicated case. We have a lot of learn from the parents, mother also. This is a last Govinda is around 8 years by I have not mentioned. All names are belongs to Vishnu, Govinda, Ranga. 8 years boy, fever with body aches and mild cough. He came from Bidadi, still I remember around 5 years back. Just for 2 days duration. So as usual, mild body ache, fever, mild cough, advice symptomatic and
Age of the child you're not-
8 years not mentioned, sir. 8 years from Bidadi. So after 1 hour, I asked him to, if required, come back, I told him. But he came back within 1.5 days only with eye spikes, cough is increased and saturation is good. But on auscultation, I can hear some crypts, left lower zone. Thought of it is as usual, till now we are discussed, community acquired pneumonia, non-severe, started an amoxicillin. Why I mentioned is because more, the preference of amoxicillin and amoxicillin is now almost equal, parallel. But in theory, we very speak about amoxicillin. But when you're writing prescription, that automatically clave will be added. Okay, thought it is a non-severe community acquired pneumonia, started amoxicillin, supportive care and advice follow. That time I advised to follow up after 48 hours. Previously I told only if it is required, come back, otherwise not required. So, but he returned back not 48 hours, within 36 hours he came with worsening symptoms. Severe chest pain now is added. On exam, decreased chest movement, left like he was standing like a sprinting.
M5
Dull note on percussion, decreased air entry, and clinical diagnosis of pneumonia with effusion was done. Chest X-ray was done, showed midline shift and all those things. Almost 2/3 of the opaque.